There is one tissue that clinicians examine more than any other when trying to determine the causes of disease in their patients. This tissue is the blood. Blood is the only fluid tissue in the body and accounts for approximately 8% of your body weight. It serves as a transport vehicle for the circulatory system, acting out many critical functions in the body, which include delivering oxygen from the lungs and nutrients from the digestive tract to body cells. When a blood vessel is damaged and causes your patient to bleed, cells within the blood form clots. This process halts further blood loss from the body and is called the hemostasis response. As a healthcare professional, it's critical that you understand the process of the hemostasis response so that you can help your patients prevent abnormal blood clots in their body. For example, a patient who remains in a hospital bed for an extended period of time may develop blood clots in their legs. These clots are known as deep vein thrombosis, or DVTs. The danger of this type of blood clot is that a piece of it could break off and travel to the lungs, causing a pulmonary embolism or even death. You can help your patients prevent these conditions by encouraging them to be active, whether that means walking, if possible, or exercising in their bed as their condition permits. Exercise helps the patient's veins push blood back up to the heart, keeping it from sitting where clots are likely to form. A solid understanding of the anatomy and physiology of the blood will enable you to help your patients prevent dangerous blood clots like DVTs.
So blood is what's inside your vessels, right? Your cardiovascular system, he is the guy that's carrying around the hormones. He's carrying around your oxygen, your carbon dioxide, whatever sort of electrolytes you need. What do you need? What do you need, little cell? I am going to bring it to you. So he's the major transporter. He also plays a role in regulation and protection. And we'll go through these slides and look at that. So, like I said, transporting things, oxygen, carbon dioxide, hormones, slides mentioning nutrients. It's getting rid of carbon dioxide through your lungs. Nitrogenous waste that's been made through metabolism, it's going to go to the kidneys so you can get rid of it. Hormones going to target organs, your whole body. Everybody's got a capillary at least passing close enough by that that cell can get what he needs to stay alive. Regulation. So body temperature is going to distribute heat. If you get hot, your vessels are going to dilate and heat is going to be lost through your skin because those vessels, as they dilate, they get closer to the surface. So help with getting rid of heat. Or if you're cold, those vessels are going to constrict and they're going to be further away from the skin, and so help make sure that the important things, your organs, are staying a nice warm temperature. We have a buffer system inside of our blood that we'll get to in a little bit, and then also to prevent shock. Your blood helps regulate your fluid volume. So how much water needs to be in there, or how much is going to end up passing through the kidneys. We need to keep a certain level to keep a certain blood pressure to stay alive. Protecting us. We have platelets and proteins that help. These proteins are clotting factors, and platelets that help with clot formation to keep you from losing blood. And then, of course, we have lots of things in our blood that help protect us from germs. So the one that you probably know about is antibodies. You probably know about white blood cells, but we even have something called complement proteins that are antibacterial. And there's a few other things that you're going to learn about too in the immune section. So what is blood made of? Well, you might remember blood is a connective tissue. It connects the whole body. It is 55% plasma and then 45% formed elements. So red cells, white cells, and platelets. If you take blood and you spin it down in a centrifuge, you can get the packed cells, the formed elements, down towards the bottom of your tube, and the plasma stays on top. Usually, it's all mixed together, though, of course. So, like I said, erythrocytes are approximately 45%. When we talk about the white cells and platelets, when you spin it down, they'll sit at the top of the formed elements, and it is an extremely thin white line, and that's called the buffy coat. The liquid part that doesn't have these cells in it, the part that has water, hormones, electrolytes, proteins, clotting factors, that's going to be the plasma. So this is showing how, okay, this person had some blood drawn from them, it got spun down, and approximately 45% of it is going to be the formed elements, white cells, red cells, platelets. 55 approximately is going to be plasma. Okay, I can't remember if this is on a slide, but I'm going to say it so I don't forget. The difference between plasma and serum doesn't have the clotting factors in it anymore. So blood is sticky. It definitely has a metallic taste. It's never blue. Your blood is never blue. So even deoxygenated blood, it still has oxygen in it. So it's lower oxygen levels, it's going to be a really dark red. High oxygen levels is going to be pretty bright. If you have an anesthetized patient that's on oxygen, you know, oxygen with the anesthetic gas, and you pull blood from that patient's blood is going to be a more brilliant red, a redder red than it would be than a person that's not on oxygen. In AMP1, you learned that the blood pH is 7.4. Well, okay, 7.35 is more acidic than 7.45. Carbon dioxide, hydrogen ions. pH is the power of hydrogen. So the 7.35 would be the deoxygenated blood because it's got more carbon dioxide / more hydrogen ions. Hydrogen ions more acidic. 7.45 would be oxygenated blood. Numbers, I don't really like to memorize numbers, but I'll tell you that it often shows up in the lab test. Males have more. They're about 5 to 6 liters. Females have 4 to 5 liters. If it is in the lab book, you need to memorize it for your lab test. Okay, plasma, the 55% of that's not the formed elements, is 90% water. But it's got a lot of stuff floating around in it. The most abundant of the solutes is proteins. Proteins, remember, they're produced by the liver. The most common one is albumin, and albumin actually does a lot of things. It helps carry things around, but most importantly, it creates osmotic pressure. It is what is holding the water on the inside of the vessel. It's what's holding your blood inside of your vessel. So if your albumin gets scary low, your vessels are going to leak. And the water that's inside of your vessels are going to leave your vessels and go out into your interstitial tissues, and you get edema. Another kind of protein are globulins. So gamma globulins are antibodies. And that's the exception that's not produced by the liver, because antibodies are going to be produced by a special kind of lymphocyte called a plasma cell. And then another kind of globulin is alpha and beta. They're going to be holding on to things and allowing things to transport around your blood, especially if it is a hydrophobic something. You need somebody to hang on to be able to mix with the blood. And then finally, another important protein is fibrinogen. Fibrinogen is going to get activated into fibrin, and it makes a mesh that creates what you might know as a scab. Other solutes, you already know this. Remember the nutrients that you ate as big pieces of carbs and lipids and proteins getting broken down? Electrolytes, gases, hormones, all those kind of things, okay? All that is in the plasma. So the formed elements, we're going to do these in lab, and we probably already have done it by the time we get to this PowerPoint. Why does this say only white blood cells are complete cells? Well, here's why. Red cells, the kind that are carrying around oxygen, are just a sac of hemoglobin. They don't have any other organelles, including a nucleus. They don't have that. They are a sac of hemoglobin. Because they don't have any organelles, they're short-lived. They can't make ATP. They don't have any mitochondria. So they're a very incomplete cell. Platelets are actually just shards off of a cell called a megakaryocyte. So platelets are what help you clot, but they're not a whole cell. White blood cells have all the organelles and everything. You remember our blood cells come from the red bone marrow, AP1. This picture is actually beautiful because this has all the different kinds of white blood cells. Another name for a red blood cell is erythrocyte. This is a neutrophil. This is a neutrophil. This is an eosinophil. The difference between an eosinophil and a neutrophil is that these little granules that are hanging out here are a little bit bigger. And then the nucleus kind of looks like earmuffs. There's a little strand right here that would go over the top of your ears. I mean, the top of your head, and this would cover your ear, and this would cover your ear. A neutrophil's nucleus is a lot more segmented. It has more pieces. Monocyte, he's going to become that cute little macrophage that goes and gobbles things out in the tissues. But in the blood, he's a monocyte. He's the largest. And the lymphocyte is the smallest of white blood cells. This actually doesn't have basophils on this picture, but they're very, very rare. Okay, so red blood cells are shaped in a certain way so that they can have as best gas exchange as possible. They're a biconcave disc shape. The center of it is more thin than the outside of it. It's tough, so you can poke on it and it will change shape, but it will stay together. It needs to be able to change shape because it's got to squeeze through some capillaries. Some capillaries are a skinnier diameter even than a red blood cell. So they need to be able to squeeze but not break. So I already said this, they are a sac of hemoglobin. The hemoglobin is what the oxygen is going to be transported on. That's the molecule he's going to transport on. Nothing new on this slide that I hadn't said. Biconcave disc offers more surface area to allow for better gas exchange. It is the sac of hemoglobin. 97% of that cell is full of hemoglobin. Red blood cells don't have any organelles. They are void of all that because they're just a sac of mitochondria. So if they don't have mitochondria, they cannot produce ATP aerobically, so they don't use oxygen for transport. What they will do is they will use glucose and do glycolysis and break down into the two pyruvates, and that's how they make their very little ATP before they die in about 4 months. So these values that I put in here are the same values as what's in the lab book. If it's in the lab book, it's potential fair game for your lab test, okay? The color, the red color, comes from heme, and the name hemoglobin actually is from heme, the pigment, and globin, the protein part. Each heme has an iron in the middle, and that is what the oxygen is going to bind to. So picture. All these little squiggly wigglies are protein strands. Some of them are alpha, some of them are beta globulins. Okay, this right here is the heme group. This is the iron, the green little dot, and so that's what the oxygen is going to bind to. So all the squiggly wigglies are the protein, and then the disc part is the heme group. The center little green dot is the iron, and that's what oxygen is going to bind to. Okay, so the purpose of these erythrocytes is to carry the oxygen. Each red blood cell has 250 million hemoglobin molecules, and so that's 1 billion oxygen molecules in one red blood cell. So when it's full of oxygen, it's going to be called oxyhemoglobin. When it has let go of its oxygen, deoxyhemoglobin. Sometimes carbon dioxide binds to hemoglobin as a hydrogen ion, and that's going to be called a carbaminohemoglobin. That's not how carbon dioxide prefers to travel, though. This is AP1, hematopoiesis, formation of red cells, white cells, and platelets. It happens in the red bone marrow in adults. That's going to be at the proximal part of the femur, the proximal humerus. It's going to be found in the vertebrae, skull, pelvic girdle. The stem cell that gives rise to all of those red cells, white cells, and platelets are called hematopoietic cells. Sometimes you might see it written as a hemocytoblast. So from the birth of an immature red blood cell to a fully mature red blood cell, it's about 15 days. A reticulocyte is what happens immediately before the most mature red blood cell. So there's different stages of immaturity. This is the last before it becomes mature. Sometimes the red blood cells, these reticulocytes, they accidentally get put into circulation. So they leave the bone marrow and they actually get put into the vessels. And you can tell them with certain stainings because you can still see a little bit of the remains of nuclear material, ribosomal RNA. If you're bleeding a lot, so you've had a bleeding problem, one way that they can tell if you're making new blood is to look for these reticulocytes in your bloodstream. So there's a certain amount that's normal in your bloodstream, but not very many. But if all of a sudden your reticulocyte count goes up in your blood draw, that means that your body is trying to replace those mature cells as fast as possible. So this is a normal red blood cell right here. Oops, there we go. There's a normal one, but this is a reticulocyte. He has got these little dots that are actually little residual RNA. Don't memorize this. This is erythropoiesis. There's actually two different sets of naming, what do you call that? Different nomenclature. So if you can remember the reticulocytes, you're doing great. This is showing the different kinds. This is a remnant, remnant of some nuclear material. This guy is an immature red blood cell. that is holding on to, you can still see all of its nuclear material. A metaerythrocyte is not what you want to find in a blood draw. Something's wrong if you're finding that. This is a type of white blood cell right there. Okay, so regulating erythropoiesis. What happens if we have too few red blood cells? Well, then we're not carrying around enough oxygen. You're not carrying around enough oxygen, your mucous membranes might be blue. No good. If you have too many red blood cells, then your blood gets too thick. It's going to start to have a hard time passing around. That's not good either. We do make a lot of red blood cells. Again, I'm not big on numbers. This is not in your lab book, so you don't have to memorize this number. But more than 2 million a second, that's a lot of red blood cell production. We balance this production and destruction based on what our body needs. So dietary requirements, how much exercise you're doing, etc. And our hormones help with that. Here's that one that I said I love so much, and I said he shows up on almost all the tests. Erythropoietin. Your kidneys make erythropoietin. It tells the bone marrow to make more red blood cells. If your kidneys are not working very good, you're not going to make erythropoietin. So if you're in kidney failure, chronic kidney failure, you're going to be anemic. But your kidneys are also going to recognize that you need more red blood cell if maybe you're not having enough iron in your diet. Maybe you lost some blood. Maybe you're going to the Rocky Mountain National Park and camping up there for, I don't know, 4 weeks, where the oxygen is, there's not as much atmospheric pressure up there, right? So the oxygen is more spread out. So every breath that you took down here in Texas is catching a X amount of oxygen, but you breathe the same rate when you go up to the Rocky Mountains. Every breath is not capturing as much oxygen. How does your body fix that? The kidneys put out erythropoietin, so you make more red blood cells. Yes, you're going to have a thicker blood because of it. More red blood cells is more ability to catch as many oxygen molecules as possible. Also, if you have lung disease, so every breath isn't getting in a normal amount of oxygen, your kidneys are going to put out more erythropoietin so that you have more red blood cells. Is your blood going to be thicker? Yes, but you need to capture as much oxygen as possible to stay alive. Here's a homeostatic imbalance. It's illegal, but athletes getting a hold of erythropoietin. We would use erythropoietin in a kidney failure patient because we don't want them to be anemic. They've already got enough problems. Their kidneys aren't working. You inject them with erythropoietin, at least you can get rid of their anemia. But some goofball gets a hold of EPO and starts injecting themselves with EPO so they can have more red blood cells, so that they can carry more oxygen, so they have better endurance. But does their blood get thicker? Yes, it does. This thick blood can cause strokes, heart attacks, clots. Dangerous. Don't do it. So what do we need to make those beautiful little red blood cells? You need lots of amino acids, right? Because hemoglobin is mostly protein. But you also need lipids. You also need carbs. You need iron, because the iron is what's going to carry the oxygen. You need vitamin B12, folic acid. So you need all these things to make red blood cells. But again, they have a short life, 4 months tops, because they don't have any organelles. They get old, they get fragile, and what's going to happen is they're going to get caught up in the spleen, usually, and the spleen is going to eat it. we have some macrophages in there. And it's going to get recycled. All those little parts are going to get broken down, and we're going to reuse all those little molecules. So the iron is going to get reused. The heme is going to be broken down into bilirubin, which is what you know is yellow. You know, when somebody is jaundiced, they're yellow. But that's okay because it's going to go through some more processes. Maybe it's going to get secreted in the bile, or maybe it's going to go into the intestines, and that's where the brown color comes from. So the bilirubin goes through some little changes, but that's okay because it's just part of the breakdown of the heme. Globin, it is a protein, so it's going to be broken down into amino acids, and then we're going to use those amino acids for something else. So anemia is when you have low oxygen carrying capability. So you're not able to carry enough oxygen. Anemia is a problem, but it's not the problem. So you have to figure out when somebody is anemic, why are they anemic? They'll be pale. Maybe their gums will be pink if it's bad. Maybe they'll be breathing harder or faster, just irregularly because they're not having enough oxygen. Pallor means pale. They're definitely going to be tired because you need oxygen to make ATP. So if you're low on oxygen, you're not making as much ATP. You're tired. And of course, you'll be cold. So how do you get anemic? Well, maybe you lost some blood. Maybe you're not making enough red blood cells, or maybe your red blood cells are being destroyed. Blood loss. That's the easy one. You get a great big boo-boo? Well, you're bleeding out. You need some more. Sometimes it's going to be a hidden bleed, though, and this is where colon cancer comes in and ulcers, and you've got to go on a search to figure out why somebody has a slow, chronic hemorrhage. Maybe you don't have enough iron. If you don't have enough iron, you can't make enough normal red blood cells. So those red blood cells are going to be small. They're not going to be having as much hemoglobin because you need iron in the middle of the heme group. So they're going to be called microcytic or microcytes, microcytic red blood cells. And of course, you just fix that by taking iron supplements or whatever. Pernicious anemia, we did this one. What if you don't have intrinsic factor? You have to have intrinsic factor to absorb your vitamin B12. If you don't have vitamin B12, your red blood cells can't spit out that nucleus like they're supposed to, so they're going to be bigger. Instead of microcytes, now they're macrocytes. But what's in the way? It's not a sack of hemoglobin now. It's some hemoglobin and then a big old nucleus in the way. So when this happens with senior citizens, they start getting injections of vitamin B12. Really, if something has destroyed your stomach, maybe an autoimmune disease, or if you've had your stomach removed, that's the only other causes there. Renal anemia, I've actually already touched on this. So if your kidneys aren't working right, you're not making EPO. If you're not making EPO, then you're not getting your red blood cells made at the bone marrow, so you get injections of it. Aplastic anemia. This is not just red cells. This is red cells, white cells, and platelets not being made in the bone marrow for some reason. So one would be some sort of drug or chemical has destroyed that red bone marrow. Sometimes it's from radiation therapy. It could be from a virus, but most of the time we don't know what causes aplastic anemia. Definitely not something you want. What if it's because your red blood cells are being destroyed? If your red blood cells are being destroyed, then that's usually going to be the sign of either something, an autoimmune disease where your body gets confused and destroys your own red blood cells, or maybe you've had a transfusion. Hopefully this doesn't happen anymore. A transfusion with the wrong kind of blood, maybe an infection, or maybe there's something wrong with your hemoglobin molecule itself, such as sickle cell anemia or thalassemias. Thalassemias is something wrong with the hemoglobin, and it is genetic. It's usually Mediterranean descent. There was 4 globin chains. You remember there's 2 beta and 2 alpha. One of those chains is either missing or it's defective. So during protein synthesis, something went wrong because the gene was incorrect. It's genetic, okay? So because one of those protein chains in there is faulty, then the red blood cells are delicate. Sickle cell. This is an interesting one. This is what we did in AP1 in lab when we did protein synthesis. Something went wrong in the creation of the protein, the beta protein, in the hemoglobin. And in the end, what happens is the red blood cell is shaped like a sickle. It's a crescent. And they clog up the tiny little capillaries because they're getting stuck because they have a little hook on them. And we found that definitely seems to happen more in Africa or African descent because of this was a genetic change. We found that people that have sickle cell anemia are basically immune to malaria. So the malaria bug can't set up house on their red blood cells, so they're not going to die of malaria. But unfortunately, there's a lot of chronic conditions that can come along with it. These people sometimes hurt as those little vessels get blocked. So, well, this is the thing that I just said. There's medicines that you can do to prevent the sickling, but what works best is stem cell transplants. There are gene therapies, nitric oxide for vasodilation. So there are treatments, there's cures. The stem cell transplant can be a cure. This is from a bird. That's all. Okay, polycythemia. Poly, too much. Too much cells. So when you have polycythemia vera, this is a type of bone marrow cancer that leads to too many red blood cells. So it's just too thick. Secondary polycythemia would be like excess EPO, or like I was talking about, if you go up into the mountains, your kidneys are going to recognize that your oxygen levels are low, so you're going to put out more EPO to make more blood. Is that going to make your blood thicker? Yes. Polycythemia, excess red blood cells. Blood doping. I think that's the next slide. No, it's not. So I'll tell you about blood doping. Blood doping is when somebody is going to do some sort of athletic event, and they take out some of their blood a couple of weeks before the actual event, and they bank it. So the blood is kept alive, in a blood bank. So they've donated that blood, so their body's going to replace it. Their body is going to fix it so that they are back up to their normal red cell percentage by the time that event comes along. And then they have that blood that they banked reinfused into their body. Again, that's too thick, polycythemia, and that can lend itself to heart attacks and strokes and blood clots. Okay, leukocytes are white blood cells. The white blood cells aren't plentiful compared to the red blood cells, but they are mighty. They are complete cells. They are also formed by the red bone marrow, and they are part of our immune system. So this number here, 4,000 to 11,000 white blood cells per microliter of blood, that's from your lab book. So that's something you should memorize. They play a huge part in preventing us from getting cooties from the outside world. They can leave our vessels. They can actually squeeze out of a capillary at that simple squamous epithelium. Remember that from AMP1. And like they'll take their phospholipid membrane and create a foot and squeeze themselves out into the interstitial space. So if the normal range of a white blood cell count is 4 to 11,000, once we go over 11,000, that's called leukocytosis. Now, if I had a patient whose white cell count was 13,000, I would not jump on the infection bandwagon. I would think that person has inflammation somewhere, like even something as simple as spraining their back, or they've done lots of exercises, maybe pulled a muscle. Some sort of inflammation can cause mild leukocytosis. That's for nursing school, but I'm throwing it out there because a lot of people jump on infection when it's the tiniest little bit elevated, and you shouldn't do that. Okay. There's two main groups of leukocytes. There's some that are called granulocytes, so they have obvious granules, and there's some agranulocytes, so they don't have granules. I say not obvious because neutrophils granules are they don't take up a lot of stain, so they're kind of hard to see. The most common white blood cell of all is a neutrophil. He is definitely the highest amount. And the least common is a basophil. So it's rare to find a basophil on a slide. In order of highest abundance to decreasing abundance, that would be neutrophils, lymphocytes, monocytes, eosinophils, and basophils. And here's this mnemonic: never let monkeys eat bananas. Or I had an SI one time tell us never let men eat beans. Whatever helps you remember their order, because that is in your lab manual, and so it's definitely a potential lab question. This is showing a differential white blood cell count, maybe a spectrophotometer that has separated out granulocytes from agranulocytes. Don't memorize this graph, but you do have to memorize the amount of different cells as based on your lab book. This is a beautiful picture of neutrophils, eosinophils, basophils, lymphocytes, and a monocyte. You can see on the left, those neutrophils do have a little bit of a stain. They're kind of pink, but look at the difference between the neutrophils nucleus, it's multi-segmented, versus the eosinophils. So the eosinophils kind of looks like earmuffs. There's two earmuffs with a skinny little line between the two of them. Also, the granules for the eosinophils are bigger, and they're more of a reddish color. The lymphocytes are pretty small, and the monocytes are quite big. The monocytes are the guys that are going to become macrophages. Okay, so the granulocytes: neutrophils, eosinophils, and basophils. They have a shorter life than a red blood cell. A neutrophil might just be alive for a few days. So They have kind of a multi-lobed nucleus instead of a circular nucleus. Basophil, actually, his granule stains so dark that sometimes you can't even really see the nucleus, but he's rare. All these guys can do phagocytosis, but the neutrophils are the biggies that do that. 60–70% of your white blood cells, neutrophils. That's from your lab book. You need to know that. They're about twice the size of a red blood cells, and they are loaded with lysosomes because they are going to destroy bacteria. Neutrophils kill bacteria. Neutrophils kill bacteria. Sometimes they're called PMNs, polymorphonuclear leukocytes, because their nucleus is so lumpy. Eosinophils, just 1 to 3%, so not very large total of all of the white blood cells. And so, like, if we were in lab, we have people searching all over the place looking for an eosinophil, and we'll find them, but they're just not that plentiful. When you do see one, you go, ah, okay, I see the earmuffs, I see the big red circles. Eosinophils are going to go up with parasites and with allergies. So allergic rhinitis, you're going to find a whole bunch of eosinophils on a cytology in your nose, for example. Animals have more parasites than, humans in America. That's not a first world problem. That's maybe a third world problem. But it can give you a clue if somebody's problems are based on a parasite if you're elsewhere. And it's not that we don't get parasites in America. We do, but in general, in America, high eosinophil count's more going to be some sort of allergic thing. So this is a neutrophil on the left. That's an eosinophil on the right. Eosinophil. Basophils, rare, less than 1%. Their granules are going to be like a purpley black, so darker. They're full of histamine, and their job is they're going to be trying to attract other white blood cells to an inflamed area. And if they get into the tissues, they're going to be called a mast cell. So mast cells releasing histamine, that's why you take antihistamine. So they do play a role in inflammation as well as the eosinophils for allergies. Can't hardly see that nucleus, but it's in there. Lymphocytes. Lymphocytes are about 25%. So neutrophils first, then lymphocytes. They're smaller than the other kinds of white cells that I've talked about, and they actually have two different kinds, T lymphocytes and B lymphocytes. On a blood smear, you would not have to differentiate the two, nor could you differentiate the two between with a regular stain, is it a T lymphocyte or a B lymphocyte? You can't. They also hang out in lymphoid tissue. So if you did a cytology on a lymph node, you'd find lots of these guys there. They have a very large nucleus. Look, he's not 2 times the size of a red cell. He's maybe 1.5 times the size of a red cell. His nucleus is huge. His cytoplasm is small. Monocytes, these guys are huge. 3 to 9% of our white blood cells, and you're going to find that you're going to get a monocytosis, so an increase in monocytes, if you have a chronic infection, so an infection that you haven't been able to clear out. These guys, sometimes when they're very busy, you can see in their cytoplasm a lot of foamy like clear vacuoles. Their nucleus is kind of kidney shaped, but the biggest thing is how large they are. These guys love to leave your blood. They like to do that diapedesis where they make a little foot and they sneak out of your capillaries and they go out into the tissues, and then they have become one of my favorite cells, the macrophage. Macrophages eat things, gobble, 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 and you can find them in lots of different kinds of cytologies. They like to also, besides bacteria, they're pretty good at getting a hold of fungus or some sort of parasite that gets into the body. Maybe you've heard of Haemophilus, or maybe you've heard of what's another little guy? Ehrlichia, tick-borne diseases, you know, those kind of things that like to get out into the tissues. Macrophages love to eat them. Monocytes and macrophages also aid in the mounting of an immune response to call more white blood cells to an area. So these are two different monocytes. The one on the right, he's just kind of scoping things around. The one on the left, there's those clear white vacuoles in the middle of him. He's busy. He's working. If he's making little clear vacuoles, he is consuming something. Incidentally, the little purple spots that are all around those monocytes right there, those are platelets. Look at this guy. This monocyte has eaten a fungus called histoplasmosis. So all of these little things, get this right here. Oh, well, I can't go back or else I'd delete my recording. So anyway, you can pause it there if you want to go back and look at it. So here's pictures again of all the different leukocytes. Here's a perfect little cytology slide right there. So this is a neutrophil. This is a neutrophil too. Why isn't he so segmented? Well, he's an immature neutrophil. He's called a band neutrophil, B-A-N-D, because his nucleus hasn't differentiated yet. So a cool thing, if you go to nursing school, you might get to learn about that. And I forget if my little pointer is on, so let me... Band. That's a band neutrophil. And where's my pointer? This is a mature neutrophil right here. Eosinophil right here. You can see he's ear muffed. So here's the band that's going between the bilobe. Here's one muff. There's two muffs. This is the part that's going across your head. This right here is a lymphocyte. He's pretty small compared to the other ones. Large nucleus, not as much cytoplasm. This guy is the biggest. He is a monocyte right there. And this guy is the rarest, less than 1% basophil. It's very common for, if you send blood off to a lab, it comes back as 0 basophils. They just didn't find one. But that's good. And this is from AMP1. This is showing the differentiation of the hemopoietic cell into all of your white cells and platelets. This doesn't show the red cell line, but there is a red cell line. So we can use different kinds of hematopoietic hormones to help you stimulate your bone marrow for like cancer patients, because maybe chemotherapy has destroyed your ability to make those guys. And we can also use these hormones to help protect AIDS patients. So we can use a lot of those hormones, especially EPO is such a common one, but colony stimulating factor is another one. Okay, disorders. So if you are producing abnormally one of those lines. So let's say your bone marrow is producing lots of lymphocytes. That's a leukemia. What's going to end up happening is you create so many of these lymphocytes. First of all, as cancers, they're not being made quite properly. They're going through division so fast that you're not getting a really normal functioning lymphocyte. Also, he's crowding out your bone marrow, so your other lines are going to get too low. Mononucleosis, that is created by a virus. And I'm going to get into that on a different slide. But that's a disorder where you get too many. Actually, it's a funny looking lymphocyte. It's so big that they thought initially that it was a monocyte. But it turned out it was an abnormally large lymphocyte. And people with mono, they don't feel good. If you get too low of a white blood cell count, that's a leukopenia. So remember, high white cell count of a normal differential. So still pretty much normal amount of neutrophils, normal amount of eosinophils. Overall, it's general. That's a leukocytosis. But when you get one abnormality of one of the lines that starts to overproduce, that's a leukemia. Lymphocytic leukemia, monocytic leukemia. That line is going to crowd out the other lines and they're not going to be able to be made. Low white blood cell count, leukopenia, and it can be because maybe some sort of drug is preventing the production of all your white blood cells, especially certain cancer fighting drugs. They'll wipe out your bone marrow, and so you have to take something to help with white cell production. Otherwise, your white cell count goes through the floor, severe leukopenia, and you can't fight day-to-day infections. Said this on the last slide, but here's talking about lymphocytic leukemias have to do with lymphocytes. So the lymphocyte line is being produced incredibly and crowding out all the other cell lines. Plus, he's not a normal lymphocyte anyway. He's cancerous. A myeloid leukemia has to do with, go back and look at that chart, the myeloblast descendant. So we're going to have the big stem cell, hemopoietic cell. One of the branches off of the hematopoietic cell is a myeloblast, and he's going to make the other white blood cell lines, not the lymphocytes. There's acute leukemias and chronic leukemias. Acutes advance quickly, and very often they're in children. Chronic is a little bit slow, and you can't say that it's good or bad. It just depends on the precise type of chronic leukemia that you have. Sometimes the chronics, you can live with them for a long time. And some of them, even though they're chronic leukemias, you still don't have much time left by the time they diagnose it. Without treating it, leukemias are fatal, but some are definitely more treatable than others, and I'm going to leave it at that. So on the left upper side, that is showing a not very honed in picture of a monocytic leukemia. As you look up close, look at all those vacuoles. So they're big, but they're not all the same size. You're making monocytes, but you're not making them like a normal monocyte should be. They should all be at approximately the same size. They should all have approximately the same kind of nucleus. And there's definitely a cytoplasm to nuclear dis ratio on these guys. And you shouldn't have that many monocytes in one slide anyway, not like that. The whole slide on the left is showing. Look at that. That's all monocytes. I see one something. To me, that looks like a mast cell, but you can't tell without being up close and personal. But you shouldn't have that many monocytes on a slide. Monocyte leukemia. Same thing. These slides, that's all lymphocytes. These are immature lymphocytes because they're quite large, so that makes them a lymphoblast. Blast is immature. That's too many. There shouldn't be that many. Remember, normal lymphocyte count, 25%. Okay, here's that infectious mononucleosis. So it's made by it's caused by a virus, the Epstein-Barr virus. It's known as the kissing disease because, well, anyway. But I got it when I was in 3rd grade, and I hadn't been kissing on anybody. And that was probably the sickest that I've ever felt. I've been sicker, but I didn't feel that bad. This one, I think I missed a month of school. Sam Darnold, New York Jets quarterback, probably 2 seasons ago, he got this and he was out. So he couldn't come back until he was well because it's so contagious. Said this already. They thought it was monocytes, that's how it got its name, but they're just weird, large lymphocytes. Okay, platelets are not actually in a cell. It's a fragment of a cell. The name of that cell is a megakaryocyte. You need them for the clotting process. They release different things. Don't memorize all of this. But in general, what they're going to do is they're going to form a temporary platelet plug for, to get the ball rolling when you need a major clot. But most of the time you just need a little clot, right? Like a kitty cat scratch or a rose bush or, whatever, little things. Platelets usually can do the job. Very short-lived, 10 days. This is from your lab book. 150,000 to 400,000 is normal. It's in your lab book, so you should memorize it. This is just showing how platelets form. So how do we clot? I already kind of made a little inference to this. To clot is to stop bleeding, and the term for that is hemostasis, blood static, stasis, stopping blood, clotting, hemostasis. Learn that term, hemostasis. So we're going to have, when you get a boo-boo, that vessels are going to create a spasm. They're also going to release chemicals that send out a message, hey, I need me some platelets. And then we're going to have a positive feedback system. One platelet comes and hangs up on a collagen fiber, he's going to release more chemicals that say, I need lots more platelets. A lot more platelets come and help complete the plug. He's going to release more signals that say, I need more platelets. And this is going to keep happening until we have a clot. It's also going to call upon other clotting factors if necessary. So, if you've cut a vessel, you've exposed the molecules that make up that vessel. So smooth muscle molecules, you're going to have some collagen, you're going to have some elastin. All these things are going to release chemicals, especially those endothelial cells, the simple squamous cells. Release some chemicals that call upon those platelets. So those platelets are sticking to the collagen fibers, positive feedback. We're going to get more and more and more platelets until we're plugged up. So we have platelets floating around in our blood all the time, but they shouldn't form a clot because there is no tear in the vessel, so there is no collagen exposed, so there is nothing to link it onto. There's a very important protein that we have called von Willebrand's factor. And he is going to be the protein that actually links the platelet to that collagen. And then we're going to have the activation of the platelets as we get more and more and more platelets to show up. Those platelets actually, when they get activated, they're going to swell, they're going to get more sticky, they're going to get spiked, and then again, they're going to release these chemicals that call upon more platelets, positive feedback. If we get a larger vessel tear, we need to call in the clotting factors. We can't just rely on platelets. And in the end, what we're going to form is a fibrin mesh. So fibrinogen is one of those things that's floating around in our blood as well. Remember, if it gets activated, it becomes fibrin, which is what ends up making what you would think of as a scab. So if we have hemostasis, we have stopped the bleeding. Sometimes you need a big old fat clot, a blood clot, and that is coagulation. It is going to reinforce that little platelet plug with fibrin and make that big mesh. So we need coagulation whenever we're having a bigger vessel break, more bleeding. So we're going to have a huge cascade of events that you do not have to memorize. You do need to remember the liver makes most of those clotting factors. They have numbers, so 1 through 13. Some diseases are more common than others, so like Leydig factor 5 deficiency is actually not that uncommon at all. You need vitamin K to make 4 of those factors. So, for example, sometimes, like the old rat poisons, blocked vitamin K. So, if you didn't have vitamin K synthesized, then you couldn't make those clotting factors. And the way to treat it was just inject somebody or something with vitamin K, whoever ate the rat poison. Now, unfortunately, we have a different kind of rat poison that has no antidote. Talk to the EPA about that. Then, calcium actually plays a massive role in blood clotting. We're going to have an intrinsic pathway and an extrinsic pathway, and you must have calcium for both of them in order to clot blood. The intrinsic pathway is called that because the clotting factors are within the blood. The extrinsic pathway is called extrinsic because those clotting factors are outside of the blood. One of them is called tissue factor. That's factor 3. This guy can bypass some of the things that happen on the inside of the blood, so it's a little bit faster, but the end goal is to get fibrinogen activated into fibrin to make that fibrin mesh to stop the blood clotting, stop the bleeding, hemostasis, to cause coagulation, that big old blood clot, stop it. Look at that pathway. Aren't you glad you don't have to memorize it? You need calcium in both. So here that's pointed out right here in the extrinsic pathway. Oh, dang it. Okay, well, sorry. Once I pass it, then I'll lose my voice if I go backwards. It won't let me go backwards, actually, without stopping the PowerPoint. So we'll just have to bear with my messes. This is an electron micrograph of that mesh, the fibrinogen that has been activated into fibrin, and it's creating a mesh to allow for coagulation, that blood clot formation, so you'll stop bleeding. What is von Willebrand's disease? People get this too. But I said von Willebrand's was the protein that binds the platelet to the collagen fiber that's been exposed. What if you're lacking von Willebrand's factor? This is bad. These breeds right here are not all-inclusive of the animals that can get von Willebrand's. But before I do a spay on a Doberman, I definitely am going to test them and see if they have von Willebrand's disease before I think about nicking their skin at all. Not to mention cutting out their uterus and their ovaries. So it's a big deal. And again, people can get that too. Okay, so now let's say we're all clotted up. We've got that great big fibrin mesh over it and everything has been repaired. We need to get rid of that clot. So that's clot retraction and fibrinolysis. So what do? What's going to end up happening is we're going to squeeze the serum out of that clot. Those fibrin strands are going to start to contract. And the goal is to start to draw the edges of the boo-boo back together. We're going to have actin and myosin in those platelets contracting and making those things shorten to help things come together. Then we got to get rid of that big old mesh, right? You got to get rid of that scab. Don't pick the scab. Let your body get rid of the scab. So usually a couple of days or several days after the clot is dissolved, you're going to have a protein called plasminogen. So remember, if something is gen, then it's the birth of. It has to get activated into plasmin, and that's going to digest the fibrin. You might have heard of tissue plasminogen activator. That's factor 7. And TPA actually can be given to somebody that's having a stroke if not too much time has passed. If somebody is having a stroke because of a blood clot that's been thrown, let's dissolve that blood clot and get blood supply going back to that part of the brain. Okay. There's a couple of different hemostatic disorders. One of them is where you form clots, especially like on the inside of your vessels when you're not supposed to, right? You're not supposed to. Your blood's supposed to flow freely. So that would be a thromboembolic disorder. Sometimes you can't form clots at all, even if you need to. So this was common in royalty. Where cousins were marrying cousins. If it's a genetic disorder, and you marry somebody in your family, they probably also have the genetic disorder. And you're more likely to have a child with that problem, right? You marry outside of the family. If you have an uncommon disease, odds are if you marry outside of the family, their dominant allele is not going to allow that child to have that disease. Anyway, DIC is a very strange disorder. It can happen because of anything. You don't know when that guy's going to show up. Disseminated intravascular coagulation. So what's going to happen first is you are going to use up all your clotting factors. So first, you're going to go through a thromboembolic disorder. You're going to get tiny little clots through your capillaries throughout your body. This is bad. But then you've used up all your clotting factors. So then you start to bleed out. In veterinary medicine, we call DIC dead in cage because you never know when that one's going to show up. It's very, very difficult to predict. It could be from being hit by a car. It could be from, or being in a car accident for a person. I guess people get hit by cars. It can be from maybe you just had a surgery and your body just didn't like that anesthetic event. It's rare. It's very rare. It can be from preeclampsia or eclampsia from pregnancy. So he's a weirdo. He shows up for many reasons, but not for any specific reasons. Okay, let's talk about those thromboembolic conditions. Definitions. A thrombus is a clot inside of an unbroken blood vessel. An embolus means that guy is now free floating. The thrombus is moving around. And an embolism is when that embolus, so the free-floating clot, lands in a spot and obstructs a vessel elsewhere. So a pulmonary embolism. Let's say you got a DVT, a big old blood clot in your veins because you have been sitting down in an airplane for an extremely long time. But I'm giggling because, what are we doing now that we're in Corona? We are sitting down doing classes all day long, sitting. So we should get up and move around. If you get a deep vein thrombosis in the leg, they tell you don't move. Because if it throws to your lungs, so it breaks free from the vein in your leg and it moves, embolizes, right? Floats through the bloodstream and he lands in your lungs and blocks off the blood supply to your lungs. So you have a pulmonary embolism. You sure could die. So that makes me want to get up and walk around because I've been doing this PowerPoint for, I don't even know, an hour. Maybe longer, probably longer, but we're almost done. Anticoagulant drugs. Aspirin. Aspirin would not get past the FDA if it were to try to get it approved right now because it does have so many side effects. Warfarin and derivatives of warfarin are also often used for people that have a problem with clotting, or if we need to make sure that that blood doesn't have a problem flowing, so we need to thin the blood, such as somebody that's already been prone to heart attacks. Heparin is often used in clinical settings if we need to pull blood and we don't want that blood to clot, but it can also be used to prevent vein thrombosis, like deep vein thrombosis, or if somebody has had heart surgery. We need to make sure that the blood stays quote unquote thin. We need it flowing. Okay, thrombocytopenia. A thrombocyte is a platelet. So if you're anemia-ish on your thrombocytes, then you're low on platelets. And what happens when you're really low on platelets? That means you're going to start to get these tiny little dots called petechia that's showing tiny areas of hemorrhage all over the place. How does this happen? Well, maybe something's going on with our red blood cells. So you've had radiation therapy, you've got cancer in that bone marrow, so they've been crowded out. There's no room to make platelets anymore. Super common. Maybe for some reason your body is destroying your own platelets. There's actually immune-mediated thrombocytopenia. Your body is eating all your platelets. So the treatment is first, give that person some platelets, then try and figure out what caused that so you can try to stop it if at all possible. Those are petechia. I told you that the liver makes clotting factors. If your liver is not working good, you're not going to be making clotting factors. Before they biopsy your liver, they're going to check and make sure that you're plentiful on clotting factors so you don't die from the biopsy. This is the one that I mentioned about the royalty from England, hemophilia. There's actually different kinds of hemophilia. Don't memorize these, but it just depends on which factor you're deficient on. But this used to be a death sentence. These children just didn't grow because, children want to go run and play and be happy and do their thing, and they fall down and they scrape their knee and they don't stop bleeding and they die. Isn't that crazy? It can be even as simple as, they're running through the hallway and they're running and playing and they bump their arm up against the wall as they're running. And you and I would bruise. But if you have hemophilia, you're going to keep bleeding under the skin. You can bleed to death just from bumping yourself. Now we can treat it with genetically engineered factors. There's that DIC. Actually, I already went into it. I forgot that I'd already gone into it. But anyway, there it is. Love to ask questions about DIC. So what happens if you start to bleed out? You're decreasing the fluid volume in your hose, right? Your vessels are just one giant hose. You have to replace that. It would be ideal to replace it with blood, but let's say you're at a car accident and the EMTs pick you up and they see that's way too much blood loss. I'm going to hook you up to an IV, at least right now, to help fill up the vessels. And it's going to be something like sodium chloride that's going to be isotonic to your blood, and it's going to be replacing electrolytes that maybe you lost from the plasma. So essentially kind of like a plasma replacement until you can get to the hospital and you get blood if you need it, because in the end you need blood to carry your oxygen. So we're going to transfuse with red blood cells. You better make sure you're getting some sort of red blood cell that's safe for you. Yes? Most of the time it's going to be whole blood. Sometimes it'll be packed red blood cells, so it doesn't have the plasma in it or the white blood cells. It's just red, but most of the time we're just do whole blood. Again, red cells don't live very long, 4 months. So the shelf life, once it's been taken out of circulation, is a little bit more than a month. So that's why we always need blood donors. You have to make sure you're getting a red cell, a blood group that is safe for you. So they're going to do blood typing. Okay, so your red blood cells, if you're getting some blood, you better make sure it's safe for you. Your red blood cells have a marker on it. Okay, it's your personal marker. And I guess I should say you might have a marker. You might have an A marker. You might have a B marker. You might have a rhesus marker, so that would make you Rh positive. But then again, maybe you don't have any markers. If you don't have any markers, you're type O. If you don't have the Rh marker, then you're Rh negative. Maybe you have both A markers and B markers. So what they're going to do is they're going to make sure what kind of blood you have before they give it to you, because certain bloods are going to need certain types of donations. This picture right here is showing that they probably put a drop of your blood here and here and here. And let's forget about this one right now. So here's your blood, and then they added something that would attack A blood. On this one, they put something that would attack B blood. On this one, they put something that would attack an Rh marker. So on this one, there's no attacking, there's no clumping, it's all just smooth blood. It looks a little watered down. There's no attack on this. We're using that as a control. B looks like smooth blood too. There's been no attack on this. On this one, we've got clumping. So what's happened is we're having antigen-antibody reactions. They're clumping up together. Same thing on this one. We're having these clumpings going on. This person would be A positive because the anti-A had a reaction. You have A blood, the anti-A attacked it, and so you've made antigen-antibody complexes. A positive. You don't have any B because there was no reaction. We'll go through this in lab too. So, that antigen often is called an agglutinogen. It is on the surface of your red blood cell. So type A has an A agglutinogen, type B has a B agglutinogen, type AB has both, type O has neither. So this slide is all inclusive. If you have type A antigens living on your red blood cell, that's your personal marker, your type A blood, you have A antigens, then you have B antibodies. If somebody gave you B blood, that means the person with B blood has B antigens. Your B antibodies are going to attack it. Your blood's going to clump up, so you're going to have little blood clots inside your vessels. That's bad. You don't want that. If you have B antigens on your red blood cell, that's yours, your B blood, you're going to have anti-A antibodies floating around. So if they accidentally gave you A blood instead of B blood, your antibodies are going to attack that blood, causing blood clots. If you're type AB, then you have both A and B antigens on your red cells, so you don't have any antibodies. You can have type A blood, you can have type B blood, you can have type AB blood, you can have O blood. You are the universal recipient. You can have anything. But if you are type O, that means you don't have any antigens on your red cells. You're going to have type A antibodies and type B antibodies. So because you don't have any sort of antigen on your red cell, you can give to anybody, but you can't receive from anybody but type O. Then there's the same thing with the rhesus factor. So if you are Rh positive, that means that you have the Rh antigen on your red cell. So you don't have any antibodies. But if you're Rh negative, well then, that's a different story. If you're Rh negative, you actually don't have antibodies to the Rh factor unless you meet some blood that has Rh antigen. How's this going to happen? Well, mom and baby's blood doesn't mix, but there is a close enough pathway that sometimes the antibodies of that baby, if mom has a baby that ends up being Rh positive because the dad has positive, some of those antibodies from some of the Rh antibodies might get detected. Some of the Rh factor might get detected by mom, and then she makes antibodies. That's not a problem for baby number 1. It's a problem for baby number 2, because if baby number 2 also is Rh positive and mom has antibodies against it, then her antibodies that she's created because of the first baby can attack the second baby. Fortunately, you can prevent this by, if somebody is Rh negative, they're going to get something called RhoGAM, which essentially is going to prevent her from developing those antibodies. She's going to get 2 injections, one at 28 weeks of gestation and then one shortly after she gives birth, so that she doesn't make those antibodies. So again, if you are Rh negative, you don't usually have an antibody against Rh. But if you're exposed because your baby is Rh positive, those antigens can pass into the blood, usually during delivery, and she will develop the antibodies, which could attack a second baby if the second baby is Rh positive. The RhoGAM prevents that. If you don't get the RhoGAM and you do end up with Rh antibodies, what's going to end up happening is that baby's blood is going to start to be destroyed, hemolyzed, and that's called erythroblastosis fetalis. Sometimes you might hear the term blue baby, right? So some of those antibodies crossed the placenta, started destroying the red blood cells of the baby. The baby needs blood transfusions. So if you get a mismatch, if you get some sort of antibody attacking your antigens, you're going to get tiny little clots, agglutination. Those little tiny clots block capillaries and small blood vessels. So what ends up happening, you have lower oxygen, and you actually, by blocking tiny little vessels, you can block up blood supply to the kidney tubules and go into kidney failure. That's the biggest thing. Could it happen to other capillaries? Absolutely. I've actually said most of these things already. How do you feel? You feel like crap. You get a fever because you're having a reaction, right? Your blood pressure drops through the floor. Your heartbeat goes fast. You feel cold. You're going to start throwing up. So we do blood typing, and that's what we did in lab. This is what I was talking about with the first slide. So this person, so this is in a laboratory setting. They take your blood out. They put it on a dish. Then they're going to start taking, they're going to put different drops on different trays. One of them is going to be testing for type A blood. So here's my blood. They're going to put anti-A on it. Do you have a reaction? Well, there you go. It's A. The next drop of blood, they're going to put anti-B on it. Do you have a reaction? If so, then you're also B. So you're AB. If you don't have reaction, then you don't have any B on you. You just had the A. Or you could say, okay, there's no reaction in A, but there is one in B. Then you're B blood. So again, this is the kind of reaction that you would be doing in a laboratory setting to determine what kind of blood you have. And then, of course, they could do it with the RH factor as well, which your lab book and your lecture book lists as D type blood, but it's the RH factor. So you can do lots of phenomenal testing with blood. You know, this is a pretty non-invasive thing. Draw some blood, urine too. That's a different lecture. And see if you can figure out what somebody has. At minimum, what you're doing is you're eliminating what they don't have. If you have normal blood work, then at least you've thrown out different things that it won't be, right? A very essential basic test. So, for example, if somebody has a low hematocrit, they have anemia. Low hemoglobin, maybe they're low on iron. Ridiculously high blood glucose, they're uncontrolled diabetic. High white blood cell count, maybe inflammation, maybe infection. Actually, a leukopenia, so a low white blood cell count, often that's some sort of virus, just for example. And then you can do a cytology on that blood. You can do a blood smear and look at the size of the red cells, the shape of the red cells. Is there anything going on inside of those white blood cells? Does it look like they caught something? Sometimes there's intracellular parasites that go set up house on red cells or white cells, and you could see those. In lab, differential white blood cell count. If you start to get an elevated monocyte count, what did I say that would be? That would be a chronic infection. A really high neutrophil count. So a neutrophilia, that's going to be from a bacterial infection usually, just for example. More specific kind of tests, checking a prothrombin and platelet counts to see, can you clot your blood? Are you clotting it fast enough? Are you clotting it too fast? These kind of things. A panel does all the chemistries like glucose and bilirubin and ALT, AST, BUN, creatinine, and all these different things can indicate different sort of problems in the body. And finally, a CBC is looking at the formed elements of your blood, so your red cells, white cells, and platelets. This test is from lab. It is very nonspecific, but they actually still run this. These numbers here are from your lab book, so you do need to know these numbers. So what they'll do is they'll set up your blood in this tube and then let it set there for an hour. And then we'll see how much of the elements have settled down in the hour. So remember, the formed elements, red cells, white cells, and platelets, are going to, you can spin them down in a centrifuge and force them down to the bottom of the tube. But if you just set it on a counter without spinning it, gravity is going to pull those guys down. So normal drop on those formed elements for man is 0 to 15 millimeters. So this little space right here, is measuring the drop in the hour of those formed elements. So when you first filled it, the red was all the way to the top. And then with time, you're going to end up with those formed elements dropping. So going down like this. So you can actually see the plasma, right? The mostly watery part of your blood that has hormones and stuff. If it's dropping faster than 0 to 15 for man, 0 to 20 for a woman, then there's inflammation somewhere in the body. Does that tell you where the inflammation is? No. But can they determine if actually something truly is going on in your body that's worth pursuing? Maybe. They're probably going to retest it again and see if it's real, because it's that nonspecific. But they do still use this test. Okay, this slide actually has maybe just a little bit too much information, but just real quick, we're going to learn when we get to the end of the semester that in a fetus, there's this little thing called a yolk sac. It's nothing like a chicken's yolk sac. It does no nutritional value whatsoever. It's going to be the initial place that we're going to make blood. Once we develop a liver and a spleen, that guy is going to also help make blood. But by the time you're done cooking for about 7 months, your red bone marrow is going to completely take over and be doing all of the blood creation. Going down to the bottom, notice these last things are written really small, so not really not a test question. But as we get older, things just don't work like they used to, and so we can develop problems in the bloodline no matter what it is, whether it's some sort of leukemia, anemia, blood clotting disorders. I think, for example, I said pernicious anemia has a tendency to show up as we get older because things don't work like they used to as when we were young. So maybe you're not making intrinsic factor, and so therefore you can't absorb your vitamin B12, so therefore you're anemic, so now you're older and you have to get vitamin B12 shots. In a nutshell, as we get older, things just don't work like they used to. And that's it.